Welcome to Fire Your Doctor with my wife, Dr. Danielle Lockwood.
And my husband, Richard Lockwood.
Hey.
Hi.
Okay, so this is our second episode. If you missed the first episode, we introduced a little bit about the inspiration behind this book, what Fire Your Doctor is all about. And today we're actually going to delve into chapter 1 a little bit. And so let's just get started. Let's see, did you have any intro things or did you just want to get right into reading an excerpt?
Well, I think as we're going through this book, it's important to point out what should be highlighted within the chapter.
Okay.
So in that case, I titled this episode, The Healthcare Monster. I think the entire book is a walkthrough to help any of the readers who are reading it to get into the mindset of what it's like to think like us, right? And think like, not even just us, but think of what I call common sense medicine.
Right.
And what it really takes to get that is we have to dismantle where the brokenness is, and we have to have a common language. So the book really sets you up for that.
Yeah. Before we do the excerpt, or maybe this is about the excerpt because I did not take notes, but she did. But I was going to ask, are we going to talk about the monster in the quote, or did you want to define a little bit more about that analogy and what that means?
I don't think it's in the quote,
Okay.
But if you want to talk about the monster, maybe we talk about that in depth after we finish the quote.
Do the quote first?
Yeah.
All right, let's get to it.
So a lot of people are talking about this medical industrial complex, and the truth is nobody really knows what it is, even though we all think we know what it is. And so this is giving a little bit of that history.
Right. We're looking at the side of this massive thing, and it's hard from each of our various vantage points to really define the entire creature that we're looking at.
Yeah, exactly.
Okay, I like that.
In the 1970s, the medical industry shifted from smaller practices and grew rapidly into large consolidated organizations and hospital-based systems. Mom and pop medicine is out, and Walmart-like hospital empires are in. Over the years, community-based hospitals closed and were gobbled up by large hospital corporations. Nursing homes became more popular as Medicare and Medicaid offered more coverage for an aging population. On the insurance front, the formation of health maintenance organizations, or HMOs, and preferred provider organizations, PPOs, led to providers being paid set pre-negotiated rates. Fewer people paid cash as insurance took over healthcare finances. Public outcry led to voters demanding change in healthcare. But it's illogical for the same lawmakers who opened the door to the Hydra of modern medicine to close it. So each phony attempt by lawmakers to fix healthcare offered temporary aid while opening the American public to even more betrayal over time. Healthcare is a big business that uses the government to enforce its monopoly. Isn't there a name for autocratic government collusion with big business? Yes, it's called a fascist state. Fascism should rightly be called corporatism, as it is the merger of corporate and government power. And that's a quote from Benito Mussolini.
We remember him from World War II.
Exactly.
All right, continuing.
How did this impact my unfortunate doctor's visit, which you can read about earlier in the chapter? Simply put, insurance, hospitals, and patients are like two wolves and a sheep negotiating what's for dinner. Guess who the sheep is. But let's get back to insurance. A small number of very large companies dominated the insurance industry, leading to a lack of competition. Lack of competition created less consumer choice. With less choice and a captive market, costs rose rapidly. Further reducing competition, some healthcare plans were only available to certain companies, employees, and residents of specific states. The insurance market became narrower, more exclusive, expensive, and complicated. The same pattern emerged in hospitals. A few big names control most hospitals and large practices. Larger hospital systems also started their own insurance companies, giving patients preferred care within their facilities. On one hand, this made it so the hospital would no longer be at odds with the insurers. But on the other hand, it strengthened hospital monopolies through the mid-late 1990s. The merger of multiple HMOs created more profit and fewer choices in health decisions. Insurance options became narrower. Patients had fewer choices. As this pattern emerged, doctor visits grew shorter, and insurance companies put more limits on the care they would pay for. The U.S. government styles itself as a neutral regulator of healthcare. Politicians campaign to fight for the working and middle class. Every new law is heralded as a revolutionary way to help people and improve lives. However, the trajectory of healthcare over time clearly shows that corporations have won and people have lost. People get less care while paying more money. Whether through incompetence or bad intentions, the government has favored the bottom line of large corporations over the U.S. taxpayer. Politicians style themselves as heroes, fighting the Hydra of healthcare, but in reality, lawmakers are just another face of the monster.
Okay, I like this. Here, let's switch back to the main feed. Okay, so where to begin with that? I think number one, let's disambiguate. I think that one of the problems that we run into is when people start hearing conversations about, well, these corporations are too big, they have too much power. Unfortunately, the response is, well, we need government regulator, we need more government, we need more government. Mm-hmm. But the problem is big government and big corporations is kind of how we got here. So more government is just going to lead to more policies that sound like a good idea, but kind of have a backdoor or an excuse or kind of some way out for, the big players.
Yeah, exactly. And I think this kind of goes to understanding what the system looked like before. We were born in the early 80s.
Yes.
Going to the doctor was a different monster than it is now. I had a very,
that's grown.
Yeah, I remember going to Dr. Heimovich, who was my doctor up until I was in fourth grade, so it was the same doctor. He knew my whole family. It was a much more personalized experience. Yep. I don't remember my parents having insurance, so I'm pretty sure they just paid to go see the doctor.
Right.
I think this is just something that if you were born after 1990, you don't know any different, and you think, well, it could never work, or there's just never a way to have a direct relationship with doctors, what about my insurance and this and that. And so I don't know. What do you think?
I have thoughts. I'm still on fascism. So let's talk about this. When we look at this kind of line between, say, like, fascism is often viewed as kind of a right-wing thing, and then socialism is kind of a left-wing thing. But the problem is, I would say that a better dividing line would be from like increased personal choice and decreased personal choice. So increasing government power and increasing corporate power versus decreasing those things. Mm-hmm. And so unfortunately, when we look at this and you're just like, oh, well, this is fascism. And fascism has kind of become this catch-all term that people have used politically as just kind of a cudgel to just beat anybody they disagree with. But functionally, what fascism always was it was a system where government cooperated with large corporations to create a command economy where, the billionaires had a seat at the table, but the individual person did not. And so the answer to that was like, well, fascism is this right-wing kind of thing, and we're going to fix it with socialism. But we've kind of ended in like more of like a mono party where there's just this ruling class that is just, at the end of the day, hospitals get more control, insurance companies get more control, government regulators get more control, and people get less.
Yeah, which makes us all confused as to why we're not getting the care that we need to. But in order to understand that, we have to understand the system that has been created around this.
Yeah. So a really interesting analogy that I really like actually is this idea of the Hydra, which is this monster in Greek mythology. It maps fairly well onto some of the read the book of Job in the Bible, in the Old Testament. You start hearing about like Leviathan and some of these, different sea monsters and entities, and you kind of get there too. What's unique about the Hydra, though, in the Greek myths is that it has like all of these different heads, and you could take on like one of those heads and, you lop off the head. We got to fix insurance, and you kind of fix insurance, but it doesn't really solve the problem. Or we need hospital reform, or we need prescription drug reform, or we need this and that and the other thing, or we need to fix government regulations, get somebody better in charge of the Food and Drug Administration. But I don't know. So why don't you just riff on that for a minute? What do you think? Hydra.
Yeah. I mean, I tend to go towards my philosophy in general is get at the cause. But what is the cause at this point? Really understanding the entanglements between all of the different industries. What's the cause? How would we remedy the situation if the Lockwoods got control of reforming the medical industrial complex? What would be the first thing that we would do?
Fundamentally, though, there's always this theme between moving into personal responsibility and freedom or slavery. And so part of the problem, we can't really kill the Hydra because many of us really need it. Like if we have half the country that is dependent on prescription medications, kind of maintenance drugs, things like that, addicted to all these bad foods, it's going to be really tough to just kind of start dismantling that without having 1 million people just kind of die without these medications that are propping them up.
That's a good point. So you can't just go after the monster, kill it.
Right. Who's at fault? Drug dealers or drug addicts?
Yeah.
And it's kind of like, it's a yes and like, so.
So I think we're headed into the personal responsibility camp of taking ownership over your own healthcare, which is why fire your doctor, right? Fire your doctor and inform yourself on how to protect you and your family. And that's going to come with some hard truths we'll get in the book for sure.
Yeah. Yeah. And so in a way, this Hydra is also, there's personal culpability in that, as we, as an entire society, enable lifestyles that result in chronic disease, injuries. And I mean, okay, maybe I'm in shape, maybe I'm physically healthy, but if I'm out on my farm spraying Roundup, then maybe I'm, contributing to those endocrine disruptors, those things like that. And so then that means that 5 years later, 10 years later, somebody that I don't even know has an autoimmune disorder. I don't know.
Yeah.
And so there's all these small ways that we're contributing to that without even knowing it.
Yeah. We have a whole chapter on toxins.
Right.
One of the things my patients will say when I am reading their report and I said, you're full of Roundup, you're full of toxins, you're full of these things that use the word endocrine disruptors. Those basically mean they're fake hormones or they disrupt the function of your hormonal system, which then lead to all the things you're complaining about. Well, they'll say something like, well, I mean, I only use Roundup once a year for the blackberries. I only use a little bit. And I saw this meme. I think it's really good. And it's like, well, there's only a little bit of aluminum in the vaccines. Well, there's only a little bit of Roundup. Well, there's only a little bit of pesticides on my vegetables. Well, there's only a little bit of arsenic in the water. Well, and you can go on and on and on. And that little bit is the thing collectively that is causing disease.
Right. And you couldn't really, and that would make it tough to point to one single cause. It's not like I just sat there and drank a gallon of Roundup and died, because they'd be like, well, you were stupid.
Yeah.
But if you, little by little, and where does that start?
Yeah.
Where does that start? It starts subtly over time, over decades. And it's just like 10, 20 years later, it's just like, well, my thyroid doesn't work, or things aren't what they used to be in the bedroom. Guess I'm just getting old, or, things like that. And then there's also the food.
Yep.
So
Absolutely.
A lot of layers. And so
Absolutely. We're gonna unwind all of that.
Yeah, that's fun.
So what do
you have in your notes?
I hear this. Yeah, that's a good question.
So I'll ask you, what was, and I'm reading off of her notes, so it's like, I'll ask you what you want me to ask you. No, but no, this is a good question. What was the most surprising thing to you as you really began to research and deep dive for the book and just in your practice?
Yeah, good question. It was almost like I came up with it.
I know. Well, somebody did, because I didn't write it.
So this idea of, I sought out in this particular chapter when I originally sat down and wrote it to try to organize, because I like things organized, and understand really when we say these words, medical industrial complex, or this medical industry, or this monster. Number one, I always want to know the history of something. And then number two, I want to know all the different parts and try to understand how they all interconnect. So as I started to do that and came to it from that theme, I found out about pharmacy benefit managers. And this is basically a middleman that is making incredible amounts of money to sell large pharmaceutical or pharmacy groups drugs. So oftentimes the price markup that you're paying is not only to pay off the research that you already paid for with your taxpayer money through the National Institute of Health.
So you're saying that drug companies are using taxpayer grants to fund drugs, and then that company then goes and sells that drug for a profit.
Yep.
When we paid for it already with our taxes.
Correct.
And then they go and sell it to a PBM. And then they make a profit. Yes. And then they sell it to corporate pharmacies who make a profit. And then finally it gets to us.
Yes. And so a good chunk of the money that you're paying is actually to pay for these pharmacy benefit managers. And they were originally created in the 1980s to be advocates for the American people to try to drive down the cost of pharmaceutical medications to give Americans fair fees, basically, for medications.
So you're saying that something that was brought in under the auspices of making prescription medications more affordable has had a net effect over decades of making prescription drugs go up.
Yep. And these pharmacy benefit managers at this point are paid for by the pharmaceutical companies as a kickback from the fees that they add on to the drugs. So, for example, let's say...
So they're like a broker.
They're a broker, yes. Okay. And they, for example, the cost of, say, we'll take a popular drug right now, Ozempic, right? It's a peptide. It's actually a natural substance that has been abused. I could do a whole podcast on that. I digress. It's owned by a pharmaceutical company, and a good chunk of that fee, they charge anywhere from $500 to $1,500 a month for this person to get access to this medication. And if you were to go through a compounding pharmacy, which is compounding pharmacies are often used to, for example, do generic drugs without fillers, or, you need a specific dosage. Naturopathic doctors and functional medicine doctors, we love compounding pharmacies. They're wonderful. And they're big supporters of natural medicine. However, $250 at a compounding pharmacy as opposed to $1,500. Okay. So that fee that you're paying, the difference is actually the kickback going to the pharmacy benefit manager to a certain extent. Let's
pause and let's talk about, I wasn't planning on talking about this, but you bring it up. So a compounding pharmacy, a little bit more background. A compounding pharmacy is where a pharmacy makes kind of semi-customized prescription medications to order, meaning like hello, I'm Dr. Lockwood. I would prescribe this medication in this dosage, and I would want you to compound it in this specific way. And so it's a one-off custom formulation of a medication, of a prescription medication. What's counterintuitive is you would think that if you were making a one-of-a-kind kind of custom or semi-custom pharmacy blend, a compound for a patient, and ordering that, you would think it would be much more expensive than an off-the-shelf generic like brand name. For example, if I had a private chef make me a customized meal for my family, that would be a lot more expensive probably than just going to a restaurant and saying, hi, I'd like a number 2.
I think it depends on the drug itself.
Okay.
So there are cases with that. And part of that is because insurance coverage versus not insurance coverage.
Right.
Some compounding pharmacies will run your insurance, take your insurance. You'll get a discount similar to what you would get at a pharmacy, like a conventional pharmacy. Okay. So it just depends on the drug. In this case, we're trying to say, well, what is the price of a drug? Like, okay, I'll take another one, progesterone, micronized progesterone.
Okay.
You can get micronized progesterone at a regular pharmacy, and we do it all the time. If you were to go pay for that through your insurance, you would be charged about $85 for a month supply.
Okay.
If we do it cash and we bypass the pharmacy, there's different websites that can do that. One of them being GoodRx, which is a great website.
Okay.
Your price is about $8.95.
Right.
So you're basically using that website, that company is basically taking what the pharmacy manager would be paid, and it's bypassing it and giving them a coupon. So it's passing the savings truly on to the customer.
And I'm sure they make a little bit of money on it.
They might, but nothing to the degree. And that was something that really, I didn't really know that was an entity that existed within. I was under the impression that most of the drugs were marked up because the U.S. is funding the majority of the research. And I always thought that was odd because we're also paying for the research. So we're paying for at least a portion of the research, somewhere between 20 and 60% of the funding to make a drug come to light is paid for by the U.S. tax dollar.
Yeah. You know, something that's really fun, as you were reading that excerpt, and this is content that I've worked a lot with as we've developed the book together. So I've worked with content a lot. This is an industry that I'm a professional in, and along with my wife. So one of the emotions that I feel most strongly working with this type of content is honestly confusion.
Yes.
And it's like, I understand it, but there's understanding. And then there's like, I need to understand this such that I can explain it to an audience in a way that they understand it. And as I'm kind of listening, kind of with a kind of empathetic listening on behalf of like, okay, is this going to make sense to people? I'm left with this emotion of confusion. And something that's really interesting that kind of goes along with this Hydra and this kind of
Leviathan
sea monster is honestly like in traditional, like in, like Judaism and your more charismatic Christianity, you'll hear about Leviathan as more than just a sea monster, or, oh no, it was actually just a crocodile. It's like, read Job again. It's not a crocodile.
Yeah.
That this is also understood as like this spiritual entity, this evil spirit, or this kind of principality that is just built on like pride, and then just kind of through shock and awe brings confusion and confusion and control and chaos. And that this was understood, from somebody in the Old Testament that was reading the book of Job in that time, would have understood like this creature is an evil entity that is bringing chaos and confusion into this world. And it's interesting that as we're looking at this, it's just like the chaos of like the deep, of that deep water. As you start looking into it, most people, and myself included, just ultimately get confused. And the true form of everything that's going on, and the way that we're being deceived, and the way that we're being taken advantage of as an American public, is hidden.
we're being lulled to sleep by the chaos and confusion of the medical industrial complex.
Right. And if I just kind of see something and I'm just like, well, this isn't good. This isn't right. This isn't good. This isn't how it should be. This isn't how I remember it. This isn't how my grandparents talk about the doctor from when they were kids. But we're just surrounded in confusion.
Yeah.
And so the emotion that I'm left with, the emotional state that I feel, even as you read that short chapter or that excerpt, is confusion. Yeah. And it's not that you're doing a great job of putting out the content and explaining what it is, but the system is confusing. And I think that's intentional.
Very intentional. Very intentional. And I think as you read through the first part and the experience that I had going to the doctor, I feel like it's so relatable, but it's so confusing. It's like, what industry exists outside of medicine? And maybe you can put that in the comment section. Remind us.
Government.
Yeah, government, but there's
taxes.
But what system allows you to show up to an appointment, not really know what the cost of the appointment is going to be, and not really knowing what you're going to be billed for at a later time, and you're going to have to owe it. And if you can't pay it, they have the right to collect the debt and put you in, credit.
Ruin your credit, attached to your house.
You're
not going to be able to buy a car.
What other system, aside from government,
taxes,
allows you to do that? And if we're not angry at this point, I don't know what is going to make us angry. I had, just flashbacks of anger as I'm writing this, but I am praying it away because I don't want that anger to be there. Exactly. I wrote down also exactly how many tax dollars are being spent just in the NIH alone. So if you don't know what the NIH is, it's the National Institute of Health. It also has a lot of things under that housing. So NIAID, the Allergy Institute and Research. It's all the research that comes through. There's a website that you can go to at this point. It's called PubMed, pubmed.com. And you have the right as a taxpayer to see any research that has been published. However, they are also putting certain ones behind paywalls and this and that to try to hide certain studies, but legally they should share it with you.
I think
so you can get most of your information from PubMed.
They hide a lot of that behind just really verbose language and things, especially if the conclusions are not politically expedient. So there's a lot of that kind of stuff going on too.
But to bring that back, I found this, and this first part of the book was written in 2020. I wrote it between 20 and 2021. And the statistic I found was after the start of COVID-19, $61 billion increase in the budget. So it was already getting like $30 billion. It increased by $60 billion after COVID-19. The NIH started getting that. I don't know if that has been rolled back at this point. I think once they get the money, they get it. I don't know. Doge might be doing something about it, but and then the average student debt, and I think this is outdated, honestly.
Oh, it's
the average student debt,
medical student,
for a doctor coming out of college, medical college, $200,453. That
sounds outdated.
It's outdated. Mine's double that. So I know that is going to be. I had a master's degree too, but I would say like that is a relatable number.
Yeah.
And it is keeping doctors enslaved into this system. They have to make a certain amount of money in order to justify the amount of debt that they are walking out for when they wanted to do something as, I would say, and I will always say this, doctors do not typically go into medicine because they want to be wealthy. They might have an idea that eventually they're going to have a good salary, but most doctors who I know go in because they wanted to help people. It is very difficult to get through medical school. It is very difficult to jump the hoops, to take the MCAT, like to do all the testing.
Yeah. It pays decent.
It pays decent. Yes, it does.
But when you look at the hours and stuff like that, it's like,
it's a lot of sacrifice.
I don't know.
So the fact that these people who are going, these doctors who are going and then walking out with that amount of debt and then getting hooked into a system where they're told this is the truth, this is the truth, this is the truth, when everything in your body is screaming that there is something wrong with this, that truly we are not helping very many people. And truly we just are getting people hooked on medications and we're not actually getting to the cause.
I think there's a lot of layers in that. Like, I mean, number one, we could have an entire book written about the increase in college administration costs and things like that, where ever since government got into the business of underwriting student loans that are, you can't go bankrupt on it, they're unforgivable. You look at, you look at inflation and then you look at tuition increases. And as soon as government started kind of pumping money into education via student loans, all of a sudden tuition costs skyrocketed far beyond inflation. I know in the last 5 years there's been pretty significant inflation, but again, we see government giving people what on the surface is going to, oh, well, we're going to open college to so many more people. Oh, this is going to be a great thing. But now that they've touched it, the costs have skyrocketed. Whereas before you would have a forcing function on, hey, this is how much a college could charge because this is how much students and families can afford.
Yeah, exactly.
And so especially for like smaller schools and stuff like that, that don't have that huge market and that huge like national draw or international draw, like not every school is Harvard.
Yeah. And I want to say, like, we'll see these beautiful buildings being, put up and they're being sponsored by insurance companies and pharmaceutical companies. That cost is not being passed down to the student. It's not like they were like, oh, well, we got a grant from X pharmaceutical company.
Oh, do you
we're
mean
going to go ahead and
that
pass
grant money is not resulting in savings?
No, it's being filtered back into the nonprofit that is the school to buy property, to buy buildings, to pay administrators. So we might see these beautiful buildings, but that isn't necessarily being passed down to the doctor, nurse, like whoever's graduating from those programs.
Well, let's talk about, nonprofit. There's a lot of these CEOs of nonprofit, in air quotes, nonprofit hospitals, nonprofit, deans, heads of departments at some of these nonprofit universities that seem to be doing like very, very well.
Yeah.
And have, perhaps like had an outsized benefit to some of these decisions.
Yeah. We touched on that in the first podcast and how it did start as a humanitarian effort. And there was even no-fee hospitals that existed in San Francisco up until the late 80s.
Now you got to pay.
And now you pay, and now it's run by Medicaid and Medicare, and the care has changed, and it's a completely, it's not these...
Nobody wants to be put in a Medicare. You talked about long-term care, and it's like nobody wants to be put in a Medicare home.
Yeah. So what do you think, Rich? What was the most surprising thing as you started to take over the book and help me edit it and kind of clean it up and add pieces and research and fill things in? What did you find to be the most surprising, particularly in this first part when we're talking about the medical industrial complex?
I didn't know about PBMs. Like PBR, what is that? Like that's something else. But let me see. There was a lot. I think working within, and in the past, at times I have worked within and kind of adjacent to hospital systems. There seems to be a culture of unintentional pride. And I don't think that most people that work at a hospital or in that system are like evil or wake up in the morning just looking in the mirror, just like me.
Yeah.
I don't mean pride in like that way. I mean pride in the sense of like where you approach the world. For instance, at times in my life, I haven't always had modern amenities, let's just say, like plumbing, things like that. I haven't always had electricity, but at this point in my life, I've arrived. And I tend to take indoor plumbing and electricity for granted. You know what I mean? And so there's a lot of these things that that we just are kind of bringing our perspective. And I think that a lot of people in that hospital system are taking a lot of things for granted as axiomatically just kind of foundational level true that aren't necessarily true. I could do an example, an easy example. Like we could go a lot deeper into this, but I'll do an easy one, and that would be, say, lab reports. And it's like, well, these are your lab reports. You need a thyroid medication when you're at these types of levels, and like this is what's going on. All right, open and shut case. Let's ride. Next. It's done. But there's actually a lot of biases built into those tests. For example, there's a lot in between you need a thyroid medication and your thyroid's functioning at optimal health. So that's number one of the things. It's meaning like, hey, your house is on fire or everything's great. And it's like, no, the smoke alarm's going off. You know, maybe there's dangerous conditions here that could lead to something. So there's a lot of steps along that path to your hormones are tanked out to the point that you need a prescription medication. The other thing I would say that's really sometimes lost in like hospital care with regard to labs would be the fact that you are biasing based on what's normal, meaning that you have a selection bias. Your lab results are compared to the selection of people that are kind of in your age group and also in your physical geographical location. And so that has a huge number of biases in it, because right now at this point, with over half the country is overweight, obese, like metabolic syndrome, diabetes, all these things are going up. The cohort of average is no longer normal. Normal is no longer healthy. Like normal is now overweight for most of our cohorts.
Yeah, we're gonna deep dive into that as we go forward.
So, I mean, I could keep going. So, so that would be just like an easy example. There's a lot of things like that. Are we talking about like?
No, we're talking. No,
like how deep are we going here? Because there's a lot of stuff that's surprising.
Yeah, I would say I'm really trying to stick to chapter 1.
Okay.
And just the medical industrial complex.
Yeah.
When as we kind of go through this again, we're really trying to introduce you to the logic of common sense medicine. Mm-hmm. And this just makes sense, right? It just makes sense. We should be thinking, all doctors should be thinking like this, right?
Right.
So people who start working with us, they work with our practice, they're like, how come my doctor never did this? And that is such a loaded question. Now I can be like, here, read the book. This is why your doctor did this.
I guess, another easy one that would be how standard of care, that's just like everybody from your most basic EMT, not even allowed to do anything cool, mainly just kind of doing transport and EMT basic, would know this. And that's, say, oxygen saturation levels. And so when we were getting into this book, what's something that really surprised me was how we saw stuff like that just kind of get thrown out. That you had hospital patients pop for COVID, and they were just sent home without medical oxygen, without a concentrator or anything. And their pulse ox readings were in the 80s, like low 80s. And it's like, everybody knows, ideally you'd like to see somebody on a blood oxygen level at least above 90, ideally above 95. A healthy person is going to be 98, 99, unless there's some kind of injuries or trauma to their hands at some point. And so seeing this kind of standard of care that everybody from somebody washing dishes in the hospital almost would know to we're sending Granny home. That's something that changed.
Yes. And we don't quite get into that in this chapter either.
I'm sorry.
However, I think it's an important point to just, it starts to bring up, how could that happen? Well, it could happen because
everybody's following orders.
Yeah, everybody's following orders. Doctors they're managed by nurse managers, charge nurses, then they get orders from this person, which gets orders from this person, which comes all the way up to we need to make sure that we're making profit for our stockholders, right? And it can go
Yeah.
all the way up to that level.
And even politically, it's just like, well, this is what we do.
Well, this is what we do. This is the protocol. And anybody who
Yeah.
questioned it, gone.
Yeah.
Right.
And so that's something for like what's traditionally called evidence-based medicine hosts, just like having like some kind of, it just did not compute. And it caused me so much just anguish, just kind of looking at just things like that.
But also historically looking back and realizing how different and how the changes that happen with, for example, what did the world look like before HMOs and PPOs? Like what did medicine actually look like? And in chapter 1, we're really talking about that. Well, it was more about a relationship. It was more direct. It was working class people who could afford going to the doctor. It was
it's incredible,
and now it's beyond a mortgage payment to have a family pay a
health insurance premiums
every month,
and then copay, co-insurance, deductibles, like this and that and the other thing. So I mean, we have a 6-year-old daughter, and we were paying $1,200 or $1,400 a month for health insurance. Didn't go see the doctor like once. I mean, maybe you got a couple like prenatal checkups or something. Yeah. And so, what would you say, $15,000, like something like that in premiums?
Easy. Yeah.
And then what was our hospital bill for overnight non-complication? Like literally like nothing. Just like we're there as a formality, just kind of hanging out so they can kind of just say hi to us. We stayed at a hotel.
Yeah.
Had the baby one night. Next, morning. All right, have fun with your baby.
Yeah.
Was it $20,000 out of pocket? Like how much?
It was it was about $18,000.
$18,000. Okay, plus the
$1,400 a month. Yeah, it was insane.
So
I think, and then come to find out, since I'm a doctor, right, I know all of the CPT codes and the coding, and I go through, they triple charged us in different areas. They double charged us. They charged us for different things we didn't even get.
Yeah.
I went through that bill with a fine tooth comb, and I actually...
Was the 18 after or before?
The 18, I think once I settled it was around 13 or 14.
Wow.
So I got a couple thousand back because...
So they literally were just kind of just typing away.
Oh
okay,
yeah,
just
double
throw this,
that. They had things on there that I got different drugs that I never got. They billed me twice for the same procedure. I mean, so that would be the other thing, is always ask for an itemized bill.
This is back to that Leviathan concept. I've just buried in page 50 of this confusing document and these CPT codes.
It took me a couple months to fight it, but I just was like, no way. So yes, I think that kind of closes out this segment here.
Yeah. If you're confused, that means that you're seeing it.
You're seeing it.
Yeah. And so that's actually something really interesting, is this concept. I think it was on Brett and Heather's podcast where they were talking about like at some point we have to just come to this realization that, so this is their idea, not mine. A system's real purpose is what it actually does. So, functionally we can call the system that we have, this is health insurance. It's going to save you money. It's going to protect your family. And we can call these government regulators, this is the affordable care for Americans. And we love cute puppies too. But functionally, what we've seen is over the decades is it's like there's this continuous like noose that's just tightening around households and families and just people just trying to afford care. Yeah, just the affordability, the Affordable Care Act. Right. And now care is so affordable. We solved that. Let's go home. Care is nuts. What is this book even for? Like, I know. Yeah. So it's we're very cautious about titles of different bills that get passed. We just are like, well, what does that actually mean? What are the patriots who love America, the Patriot Act, and all this kind of stuff. And you're like, oh yeah, that's great. What did it really do? And so I think that functionally looking at some of these things is like, what has the net effect been? And it's been people have less access to affordable health care. We have less access to choice of doctor. We have less access to medicines. We're getting more prescription medicines pushed on us that honestly people didn't really need. And so we have more problems, and less personal choice, less personal agency. Yeah.
we'll continue on.
Yeah.
We have hope in this book too. I just want to say that we have hope, but part of understanding and getting to the hopefulness is to understand the monster that we're fighting.
Right. And I think that's, there's this, it's a Bible quote. It's actually from Revelation. We use it later in the book. I forget which chapter, but there's this angel crying out to the people, and it says, like, come out of her, come out of Babylon, my people. And it's like it's a command, but it's also an if-else statement. So it's like, come out of her, my people, come out of Babylon, or you will share in the plagues. And like, I think there's the way of hope is to just come out of this entire system that has been built around this monster that is the medical industrial complex.
Bring it back to the people.
Yeah.
Yes. Well, thank you.
Thanks for listening.
Have a great one. We'll see you soon.
All right.